Wow, I'm tired today. Anyway, so he's going to be here. He's training us on patient assessment tonight. So just please give him your best attention. You're more important.
Hey, Nancy.
All right, guys, how you doing? Wow, a lot of faces. This is huge. Some of you I know, some of you I know really well. Some of you will get to know me. I'm a lot of bark. I don't really bite that often. If I'm biting, you know you're really messed up. But okay, John Porter's worked at Stanford, and over the last year I've been the 92 medic, so you'll be seeing a lot of me. We're going to talk just about patient assessment, and one of the things I want to get away from is that notepad. Okay, that pad that everybody goes out on their checklist and stuff. Some of you may have seen like where I've just stopped your interview because like somebody's been altered mental and you're asking questions and they're asking questions. I'm like, it's over. They don't know what they're talking about. Okay, so if they're confused, don't ask them these ridiculous questions. Just they're confused. Figure it out there. As far as assessment, I want to teach you like a rapid, like 30-second size up. All right. So does anybody think that's unreasonable to do a 30-second size up? All right. Those of you who are working with me, like Gail and stuff like that, I really focus on a very palpable exam. You know, just touching people. If you don't touch them and you sit there and you stay back with your pad and your pen and you ask questions, you're not getting information because 9 times out of 10 they're lying to you. Okay. You do any drugs? Oh no, I don't do any drugs. Right. Okay. You know, you've been drinking? No, I haven't been drinking. Right. Okay. So, but these are all things you can figure out. You can smell alcohol. You're like, you ever been drinking? Really? Okay. So, you know, just a palpable exam, getting up in their face and figuring out what's going on. So, to determine if somebody's really like unstable, stable, whatever, we'll just start with the basics. Okay. When you walk up to somebody and you know you're just talking, the first thing I do is like I grab their pulse, just feel their radial pulse and talk to them. And as they're talking, I can figure out if they're slurring their words, if they're conscious enough, if they have a slow heart rate, they have a fast heart rate, get the skin temperature, is it cool, is it clammy, is it warm, is it hot, is it dry, is it wet? These are all things I'm figuring out just looking at them and just touching, taking a radial pulse. So if they have a radial pulse, what does that tell you? Anybody?
At least 80.
What's that?
At least 80 systolic.
Some would say 90, 80, 90. Okay, in between 80 and 90. It tells you that they have a blood pressure. You know, speaking of like taking a pulse, I was with a guy the other day, and I'm like, look, is it regular, irregular? Is it slow, is it fast? Because I'm looking at something on the monitor that he has no idea, and I explained it to him later, and I'm like, because I'm looking at the monitor, for example, and the heart rate says it's 88, all right? So he just happens to say, oh yeah, the heart rate's 88. I'm like, are you sure? Okay, because this person had a ventricular dysrhythmia, which happens to be called ventricular bigemic, where they have a regular beat and then they have a ventricular escape beat, and whether that is perfusing ectopy or non-perfusing ectopy could make a difference in my treatment. So because if the rate's 88 and every other beat is a ventricular beat, if it's not perfusing, his actual heart rate's 44. But if it's perfusing ectopy, the heart rate's 88. So it's the difference between, like, if he says it's 88 because he looked at the machine and I took his word for it and I gave him lidocaine, I just killed that person. And they're never coming back. Okay? So it's very important to say, I don't know. If you don't know, I can't feel it. Or if it's regular, slow, fast, these are all things because the actual treatment, if the heart rate was 44, would have been atropine to speed up the heart rate and the ectopy will go away, instead of treating the ectopy, which his heart rate's too slow, and then kill him. All right? So these are all things we're going to hear. Are you sure? Are you sure? Or and don't be offended if somebody double checks your work, because it's important. I have my partners all the time double check every medicine I push. Anybody here work with me? Every time I push a medication, what do? Read it, make sure it's the same thing I said. I need to take it to the bag and then push it just to make sure it's a quality assurance thing. Because you have people that grab the wrong medication or whatever, and you kill people. But anyway, so for blood pressure, what does blood pressure equal? Just feel free to talk, don't be shy. Cardiac, Robbie knows, Robbie, I know you know. Okay? I know Robbie knows, anybody besides Robbie.
Cardiac output, peripheral resistance.
That's right. Cardiac output times peripheral vascular resistance. What does that even mean? What's peripheral vascular resistance? Intermediates in the room?
The amount of pressure it takes to push the blood through.
That blood, peripheral vascular resistance has to do with the amount of blood in your container. You have a container, okay? Yeah, let's just say you have 1 gallon, right? Now you're leaking blood, so you have less than a gallon, okay? You want to know if there's vascular resistance. Are your veins dilated for some kind of etiology of shock, or are you hemorrhaging somewhere? Okay, so that's one reason to make your blood pressure go down. So if this is low, this is low. Cardiac output, that has to do with your heart rate, okay? Is it slow? Is it fast? Is it confusing or not? These are all little indicators. So by just taking a radial pulse and finding out if they have fast heart rate, regular, irregular, or if it's too slow, maybe you can't feel it. The blood pressure may be low, so you can't feel a radial pulse. So stop sitting there trying to take a blood pressure. You see people, they get hooked. You gotta get that blood pressure. Somebody told me to get the blood pressure. And everybody's aiming to please and not disappoint, and they're trying to get a blood pressure, trying to get a blood pressure. And you're like, do they have a radial pulse? Well, I'm not sure. Well, that's a good start. Start with a radial pulse. If they have a radial pulse, you know that the pressure's there, you just can't find it. It's just like finding somebody, if they're breathing, they have a pulse, you just gotta find it. Okay? There's no non-heart beating breathers out there. All right? So you just gotta find it. So now, when you roll up, you can sit there and tell if somebody's pale, you can tell if they're cool. Another one is capillary refill. Look under the conjunctiva of their eyes. Just pull their eyelids down. If they're pink, good, perfusing. If they're white, they're bleeding somewhere. They are bleeding somewhere significantly. Okay? So, you know, when you think of somebody's bleeding and it's non-traumatic related, so what do you think? Differentially, what do you think? If somebody's got, you know, they got a terrible blood pressure, they're pale, their conjunctiva, their skin's pale. Internal bleeding, right? Or external bleeding, okay? If you missed that, I mean, if you missed that, you're in trouble, all right? You don't want to miss that. So, yeah, internal bleeding, such as GI bleed, lower GI bleed. They probably don't even know that they had a lower GI bleed. They've probably been pooping some black tarry stool for days. Well, why would they be doing that? It could be just a spontaneous medical GI bleed, or it could be a contributor of some people are on blood thinners, right? Blood thinners, great. They save elderly people, but they also kill them, right? Why? It thins their blood. Virtually, blood thinners, they make people virtual hemophiliacs overnight, okay? And there's all these new blood thinners out there now. There was only one really that was out there, it was Coumadin. Everybody familiar with Coumadin? Warfarin, they call it, or whatever. The problem with that, from my experience with it too, is there's no like weight-based, like, oh, you weigh this much, this is how much milligrams you get. They kind of like play it, and they draw some blood, they draw what's called a PTINR, it's a prothrombin time to see what your clotting factor is. And like, so 2 milligrams might be great for me, and 2 milligrams for Mr. Hammer might just be over-thinning him, and it gives him a spontaneous stroke, or rectal bleeding, or upper GI bleeding, any number of things, you know. So then they try to, you know, fix it. So they start giving fresh frozen plasma, they start giving all this crazy stuff to try to bring up the clotting factor. All right. We're going out. This is gonna be quick. So, who are new EMTs? Everybody all EMTs? Who are the intermediates in here? What is your job? I drilled it to you.
Patient assessment.
Your job is patient assessment, and that's all it is. Okay? Sticking people. If you're not getting the right assessment, you're not doing anybody any favor by putting in a small IV if they needed a big IV. You know what I mean? It's all about patient assessment and recognizing it. And the people that are under you, your subordinates, you need to tell them, we got to move. Gail's kids, one time they were sitting there all in this assessment, we're in a restaurant or whatever, and I just moved them aside, I'm like, grab the guy, we have no time for this. This guy's circling a drink, all right? It was like, we got to go. And, you know, just looking at him, he just looked like that. And had a girl the other day too, I was like, hey, you have your Lucas? She's like, yeah. I'm like, now would be a good time to pull that thing out. She's like, well, why? I go, because she's gonna die. Okay? I mean, her face just went flat, you know? She's like, what? I'm like, yeah, you might want to get that. So I mean, it's all about being prepared. So, you know, you have, like, unfortunately, I came in later in the incident, you know, coming in with as a fresh set of eyes, whether the 50's there or not there, the EMTs, it's always about reevaluating the whole scene. So, like I came in, they're like, oh, it's a nausea, vomiting, blah, blah, blah. I'm like, any blood thinners? No. I'm like, sure, yeah, somebody else has a list of paperwork, somebody else, that's fine. I'm trying to put it all together, and I was like, look at give me the list, you know, I want to see it. And it just happened to be.
Dispatch to post 53, first response, priority 1 with a medic, 1441 Post Road, the library, the lobby for the unknown age female, unconscious, repeating post 53.
Let's see if they get a good assessment before I get
First
to
response, priority 1441 Post Road,
again.
between Norwell Circle and Grab, the unknown age female, unconscious, time on 1945.
Is that there? And doing a rapid assessment? Sorry, I gotta go to this one. All right. Alright. Yeah, yeah. No, I'm sorry. I'm really good. Rapid assessment stuff.